Welcome to AI Podcasts. Today we're digging into a new AAAI paper called IMQC, a large language model platform for medical quality control.
And the quick version for busy listeners?
IMQC takes the messy rules hospitals use to judge care quality and turns them into a consistent, machine-readable playbook. Then an EMR-aware language model runs those rules on patient records at city scale. In a real deployment in Shanghai, it hit around human-level accuracy, processed records dramatically faster than manual review, and was recognized at OpenAI's Innovative Applications of AI track.
So this isn't a lab demo, it's actually running. Before we go deeper, who's behind it?
The team is led by Qi Ye, with senior author Tong Ruan, based at East China University of Science and Technology, working with the Shanghai Medical Quality Management Center and collaborators.
Got it. Let's set the stage. What problem are they solving exactly?
Hospitals track quality indicators to make sure care follows guidelines. Think of them as standardized questions like, for heart attack patients, did they get the right medication within the right time window? Traditionally, people comb through charts to answer those questions. It's slow, expensive, and error-prone because the evidence is scattered across free text notes, codes, labs, and timestamps.
Right, and every indicator is a little rule puzzle. You need to find who qualifies, then check whether the care matched the rule. Denominator, then numerator, like a fraction.
Exactly. Denominator is who's eligible. Numerator is who got the recommended care. Past research tried two routes. One, build a custom pipeline per indicator, lots of brittle, handcrafted logic. Two, prompt a general LLM and hope it understands both the facts in the chart and the rule semantics end-to-end. That's elegant in theory, but in practice it can be inconsistent and hard to audit.
So where does IMQC land on that spectrum?
They split the difference, and this is the key idea. First, translate each indicator into a standardized representation, basically a clear rule language the computer can run. Then use an EMR-focused language model to extract clinical facts from the record and apply those rules. You can think of it like tax preparation software. The tax code is the indicator language, and the model is the assistant that pulls the right numbers from your receipts and forms.
Nice analogy. I'm curious about that rule language. Is it just if-then statements or something more?
From what the authors describe, it captures eligibility logic, temporal constraints, and evidence requirements in a consistent schema. Not just if-then, but also timing like within 24 hours, and linkages between events. Like medication given after diagnosis, but before discharge. The point is to remove ambiguity so two hospitals interpret the indicator the same way.
And the model, the EMR LLM, what's special about it?
It's tuned for clinical text and structured data. Its main jobs are to verify facts, who the patient is, what happened, when, and to surface those facts to the rule engine. There's a useful discipline here, separate fact extraction from rule reasoning. Instead of asking a model to magically output the final yes or no, the system builds a traceable path. Here are the facts, here's how the rule evaluated.
Which helps with auditing. If a hospital wants to know why a case was counted or not, they can follow the breadcrumbs. All right, what did they test in the real world?
The deployment started in early 2024 in Shanghai under the city's Medical Quality Center. The scope was big, over 1,000 indicators applied across dozens of hospitals.
That's a lot. How did it do?
In aggregate, accuracy was in the low 90% range when compared to human experts. Throughput jumped massively, from the pace of a trained reviewer working case by case to more than 1,000 records per hour on a single high-end GPU. That kind of speed is what turns a monthly reporting crunch into near real-time monitoring.
And the money question, literally, did they talk about costs?
They estimated meaningful monthly savings in staffing effort. The exact figure will vary by place, but the direction is clear. Once you automate the tedious parts, people can spend time on the exceptions and on improving care rather than counting cases.
Makes sense. I want to double-click on why this worked. Is the secret sauce the language model or the indicator language?
Both, but if I had to pick, I'd say the indicator language. When rules are precise, the model has a narrower task. Find the facts that matter and line them up against a template. It's the difference between asking someone to write an essay about a vacation and asking them to fill out a customs form. The second is faster and more consistent.
Huh. And also more likely to get you through the airport. Let me play skeptic for a minute. What should we be cautious about?
First, generalizability. This was built around Chinese EMRs with local coding practices and language. Porting to a different country means new data schemas, different clinical notes, and new indicator definitions. Second, the headline accuracy is an average. Some indicators are straightforward, like did the lab exist, while others involve subtle timing or contraindications. We need per indicator breakdowns to know where human review is still essential.
Mm-hmm. And transparency? Can others read or adopt the rule language?
That's another open question. Publishing the formal spec would help regulators, hospital IT teams, and vendors interoperate and audit. It would also let people map indicators to standards like FHIR, ICD, and LOINC, so the same rule can run on different systems without guesswork.
What about safety? If the model quietly misses something, that could skew a hospital's quality report.
Exactly. The platform needs robust guardrails, uncertainty signals when evidence is weak, automatic flags for edge cases, and a human-in-the-loop workflow where tricky charts get routed to experts. Regular auditing is key too. Sample cases, adjudication protocols, and drift monitoring as notes and workflows evolve.
Let's talk authors again, but briefly. You mentioned Chi Ye and Tong Ruan. Any signals from their prior work that feed into this?
Yes, they've studied how to break down quality calculations into fact-checking and rule reasoning, showing that structure matters more than clever prompting. That design philosophy is carried into the platform.
So, it's not just a bigger model, it's a better framing of the task. Okay, if you were advising a health system that's interested, what would you say are the first steps?
3 quick ones. First, inventory your indicators and harmonize their definitions. Turn pros into testable rules, even if it starts as a spreadsheet. Second, map your EMR fields and note types to those rules so you know what evidence exists and where. Third, stand up a pilot with a small indicator set, publish the per indicator accuracy, and create an escalation path for uncertain cases.
And on the research side, what's next?
Open up the indicator language and APIs so others can audit and contribute. Replicate across multiple hospitals and languages with pre-registered evaluation plans. And add uncertainty and explanation features directly to the user interface so reviewers can see why a case was counted and how confident the system is.
I like that. Confidence plus explanation builds trust. Before we wrap, can we restate the core takeaway?
Sure. IMQC shows that if you formalize quality rules and pair them with an EMR-savvy language model, you can automate a big chunk of clinical quality reporting at scale with near-human accuracy and dramatically higher speed. It's a practical step from clever demos to infrastructure.
And the caveat is, don't skip governance. Share the rulebook, measure performance per indicator, and keep people in the loop where it matters.
Exactly. Do that, and you turn AI from a black box into a dependable part of the hospital's quality engine.
All right, that's our coffee chat on IMQC. If you're in health IT or quality management, this is one to watch.
Thanks for listening to AI Podcasts. We'll be back soon with more research you can use.